Thank you, Dawn, for joining us today. My name is Diane Cook, and I'll introduce our speaker who is giving us a talk as part of our GSUR seminar series. This is Dr. Dawn Mechanic-Hamilton from University of Pennsylvania, and we're excited that she is coming and talking about digital assessment techniques because that's of interest for all of us in this group. Dr. Mechanic-Hamilton earned her PhD in clinical psychology with a concentration in neuropsychology from Drexel, and she's completed postdoc internships and studies and positions at Brown, University of Pennsylvania, and is now an assistant professor in the Department of Neurology, chief of the Division of Neuropsychology, clinical core lead in the Penn ADRD, and has many other activities and projects going on. So I will turn it over to you to share with us some of what you are working on, and thank you.
Thank you. Thanks so much for the invitation. I think this is, it was really exciting to hear that there was a group that comes together to think about, learn about, and move forward some of these areas of work. So very excited to be able to talk to you today. So I'll share my screen. And let me just get this all set up and we can go to full screen. Okay, so you're seeing the correct one, the full screen. Great. Okay. All right, great. So, as Diana mentioned, I'm a neuropsychologist in the neurology department at Penn, and I do a lot of work with our Alzheimer's Disease Research Center. What I'll talk to you about today is some work that I'm doing as part of, so originally part of an Alzheimer's Association small grant, and then now part of my K23 award. So in the process of continuing to collect data for this award, I think that since we're a little short on time, I have kind of two projects I was going to focus on, but maybe I'll just focus on the first one and just briefly mention the second, since the second one was just published. So it's actually out there, which is exciting. So, you know, I think we're all thinking a lot about the ways in which we can improve assessment and intervention, and lots more tools now available to us, almost a dizzying number of tools available. And so I think thinking about sort of when they're useful and how they're useful and the components that are useful is something that I think is helpful to have conversation about and figure out when they're going to add value and how to do that. Now, I'll talk to you today about some of the trends in technology use. I think many in this group are probably pretty familiar with this, so I'll go through that pretty quickly. Some current approaches to tech-based cognitive assessment, and then here I mentioned the two, but I'll focus more on the assessment in preclinical AD. So just an overview of what we'll talk about today. And so, you know, thinking about tech and older adults, the population that I typically work with, when I started doing work in intervention at the Penn Memory Center, when I was just finishing postdoc a little over 10 years ago, most of the people coming into our groups were not using smartphones and were not using a lot of technology. And that changed dramatically over the following 5 years to 10 years. And so, you know, and it was about this period of time. And so just watching that happen in the clinic and in our research settings, and the changes that we saw, and probably in our everyday lives too, with family and friends, you know, we really see this incredible growth in the use of particularly smartphones in the 65 plus group. And so I imagine I'm kind of preaching to the choir in terms of thinking about technology as being a reasonable tool in this population. But I think we're seeing that more and more day to day within our population of participants and patients. Use of social media also increasing. We don't use that in my particular research, but I know others do. And it's very relevant to, everyday life. So this is a gratuitous picture of my son and my mother getting together to, share information about how to access things online. And this is, I think, a scene from lots of people's houses and, clinics of incorporating technology in lots of different ways across generations. So I think there's lots of opportunity, intergenerational opportunity, and particularly in our older adult population. And one thing that I think about a lot with technology is access to the technology itself, and being able to increase access to things that are happening in the clinic and the research spaces through the use of technology. And I think one of the areas that we see the most access in is in smartphone use. And in particular, I'm thinking about access across racial and ethnic groups, different socioeconomic status groups. And we see, particularly in those in marginalized groups within the US, that smartphone use is really quite high. And so that's the route that we went in terms of the technology that we were using for assessment. And it's not, it's something that I think lots of different groups are doing and seeing and making use of smartphone, but both in the US and globally, thinking about people like Rhoda Au's work across the globe. So, when I'm thinking about adding technology, the things that I'm often thinking about, like I mentioned, increasing access, I'm really interested in ways to reach more patients and participants, people in rural areas, people who have burdens to coming in, financial burdens, time burdens to getting into the clinic, getting into research spaces. And that ability to kind of reach out into remote settings allows us to both collect data remotely and frequently and reduce that burden to that data collection, but it also can connect patients and care partners and clinicians and researchers at a distance in a way that, we can see, is it reliable? Is it valid? Those are the questions that I have when I'm looking at this technology, but certainly there's that possibility and that potential. Some of the added benefits when I think of, adding technology, I think of the unique features, because if we're just doing the same thing, from same things as we do in the clinic, that could add value, because it could add the value of being able to do it remotely and doing it the same, but at a distance has value. But then there are also technology specific values. And so I think some of the things that we try to think about in developing different tools is the use of visual enhancements, audible alerts for people, for things like prompting technology, being able to capture different kinds of data, trial level data, accuracy, reaction time, being able to use adjusting types of tasks to adjust to the performance of the individual, and then self-administration in order to reduce burden on clinicians, which we are always low on clinicians, and our clinics are filled to capacity often. And so ways in which we could sort of extend the reach of clinical practice as well, in some way, for things like screening measures and those sorts of things. So I just, took a quick look at the literature just to see what this looks like over time. And there's just a huge increase, especially in the last 8 or so years, in the interest in mobile cognitive assessment. And I think even in the last 3 or 4 years, it's just gone up exponentially in terms of the groups that I'm seeing at meetings that are talking about using assessments, remote assessments, and being able to do that in a reliable way. So I just wanted to review briefly some of the approaches that I've seen to tech-based assessment. Sort of just generally thinking about these different ways in which people have approached it. So one is to take typical paper pencil tests and create computerized versions, kind of a direct move from standard administration to electronic measurement. And that can really help for standardization of doing the tasks, for very quick scoring, can help with increasing the potential for using things like item response theory to the methods for reducing the time burden on doing these kinds of tasks. Once they're ported over and norms are established, these are tests that we're used to using, so they feel familiar to us, and we have a sense of what they are testing. Other approaches to tech-based assessment that are really collecting additional data, so metadata beyond sort of the typical variables of accuracy and time to completion. So a good example of this is the digital clock test, where you're asking the person to do this typical thing that you would want them to do, is draw a clock, but you're collecting just a tremendous amount of data with that test using sort of a digital capture. And so these are some, that's another approach that people have taken. Passive data collection using wearables and environmental sensors. This is just an immense field with so many different approaches and a really rich amount of data that is being collected. And I know folks at your university and many others are doing this kind of data collection, where we can really get a digital picture to show how people are successfully and not so successfully kind of moving through their day, and errors that are coming up, or you can see this going in either direction for people who are going through a recovery process, in improvement in tasks over the course of time, or decline in the case of neurodegeneration. So this is, I think, an incredibly exciting area, and we're just kind of dipping our toes in this, in adding a wearable to some of our data. So having people wear a watch to collect some activity, sleep data, those sorts of things, but we haven't quite yet looked at that. So another approach is really just kind of straight gamification, taking games that are already out there and kind of trying to pull out variables that are already in those tasks, and really taking a game and seeing what we can learn about cognitive function based on that. And lastly, I think this is the one I've been hearing a lot about in many different settings. And so this is some work by Jason Hassenstab at WashU and Kate Papp at Harvard. These are really taking experimental cognitive measures and digitizing them, and using them in populations, both early onset and then with the branch up in Boston, using it in early detection of cognitive change. And so I think a lot of each one of these approaches can offer different types of important pieces of assessment that you can put together in different ways, and some may be better than others depending on the population and the questions that you're asking. For our purposes, we chose to use some gamification and using some experimental cognitive measures, as well as some sort of typical paper and pencil tests that we gamified. And so I'll tell you about those in a few minutes. Some of the questions that we were asking ourselves when we were thinking about creating a task is, device choice. So are you going to be doing this on a device that you're giving the person, or are they bringing their own? And Jason Hassenstab has done some really nice work at looking at the differences across devices, and how you can see really a lot of performance differences across devices, and making choices about that is really important because people don't want to have a second phone. But then there's a lot of variability if you have them use all of their phones. So the choice we made was to give people phones. So we've got the same phone we're using, but they don't like it, right? They don't like us giving them a second phone. So we're contending with that. Whether or not to just be doing this in person or be giving this to people to take home, or sending them out to take home and use at home. We're doing both. So we're having people do the tasks in the clinic and at home so that we can look at that. Monitored or unsupervised, we're sort of doing a mix of that too, since we're doing at home and in the field. Single versus multiple time points. We're doing multiple time points because we really want to get a large amount of data and be able to look over a longer period of time. And we're doing mostly active data collection. The passive sort of home-based device data collection we're not doing, but we are doing some passive data collection in that we're collecting data on activity on a watch. So those are some of the choices that we made. I think you could argue both ways for some of these things, and it really depends on your population and what makes sense and the feasibility. But those are the things that we were thinking about in terms of what we want, how we wanted to do it. And then in terms of what we wanted to do, we were really interested in early detection of cognitive change in those at risk for Alzheimer's disease and related dementias. So, thinking about some of the tests that are out there right now, the PAC or the preclinical Alzheimer's cognitive composite is one of the in-person paper and pencil tests that have been shown to identify differences between those who are positive and negative for amyloid. And that is our goal over time, to be able to, make that distinction as early as possible in potential research participants and also clinical patients, something that's becoming even more important as lecanemab and other kinds of drugs and treatments are coming to market. So that was sort of our thought, was that we wanted to really target the earliest areas of change in Alzheimer's disease, and one of our tests is really focused on that. I show this to you just to sort of drive home the idea of individual heterogeneity. Anyone who does cognitive testing, we know that, people perform differently on different days. If we look at the PAC at the bottom right, and we look at the differences between the two time points here or here or here in these three different groups, there's a lot of heterogeneity. There's a lot of change in the way in people perform up and down, and you can see that change from day to day. And I think the digital assessment allows you to collect a lot more information so that you can capture both those differences, but also over time trends that are more based on continuous performance rather than on one time point versus one other time point, which may not really represent where they're at in that stage. And so collecting that large amount of data can be really helpful. So our mission was to develop a cognitive app for trying to detect and monitor change in preclinical Alzheimer's disease, with two areas of focus: finding the most appropriate research participants, improving detection of early cognitive change in that group, and really trying to think about reducing bias and burden in our tests, and increasing engagement, reliability, and the frequency that we can do our tests so that we can have more of that data to identify those changes. So our goals were to develop a suite of cognitive tests to detect those changes, evaluate people's willingness to do it, take it home, and participate, and validate it against some currently used cognitive tests. And in the future, we're currently collecting neuroimaging data in this population, so MRI, amyloid PET, tau PET, plasma biomarkers, so that we will be able to look at that within these groups as well. But this is the first of the 3 tests. So I said we did some gamification with some cognitive neuroscience approach. We really were interested in some of the areas of memory, the aspects of memory that are impacted earliest on in Alzheimer's disease-related dementia. So thinking about the areas where there is tau deposit earliest on. So some extra hippocampal areas, entorhinal and perirhinal cortex. And we know that those areas really are necessary for things like pattern separation and being able to sort of distinguish between similar items. And so we combined kind of a typical, flip card memory game, maybe you played when you were a kid, on a phone. So the idea being that, you see the back, so you see all of the items, they flip over, and then you have to find them and you have to identify them. So a relatively simple game that people generally kind of know the approach of if you show them once. It's a pretty simple process. And there, we're looking at object recognition memory, we're looking at spatial memory, pattern separation, and over time an increasing memory load. So this adjusts to the performance of the individual. If they are able to clear one level, it gets harder, they get more cards, and it goes up and up and up. You can see here, I just want to point out what we call the lure levels. So these are levels where there are similar items that people have a little bit more difficulty distinguishing between. So these are very similar markers here, and then these are similar egg cartons, whereas this set here, these are very distinct items, and so they're much easier to remember the differences. So we'll be looking at some of that data later that comes out of this. So the second of the 3 tasks is a combination of a gamification and the Stroop test. So if you imagine Tetris, but a Stroop version, that's what this is. And it's got 3 different blocks. The first one is speeded word reading. So matching the word that's there with the buttons at the bottom. The next is the colors. And the next one, of course, is the response inhibition task. So here identifying the word, the color, and not reading the word. And so that was the second one. We really wanted to have a reaction time and response inhibition task. And then the third one is, if you can imagine, a combination of digit symbol, a digit symbol type of test combined with Space Invaders. So here you have pairs of symbols and numbers, and one at a time, these sort of burst and pop, and you can see the symbol, and you have to identify the number that goes with it. This, again, has increasing numbers of target pairs, so it starts out easier at 4, and then 5, and then at 6. We do some incidental learning of the pairs at the end as well. And so those 3 tasks are on a phone that we give to participants. This is our basic setup for our study. So we have, these are the folks that are in our study. They're in our ABC cohort, which is our clinical core of our ADRC, our Alzheimer's Disease Research Center. And we're recruiting right now only cognitively unimpaired folks who are willing to use a smartphone. They do not have to have any experience with one, but just willing to try. And we have some people who don't use smartphones, but most of them do in our cohort. We've only had one person of our cohort say no, no because of the technology. Others will say no because I'm traveling or other reasons, but only one that has said no specifically because of the technology. So we have a baseline where we do some cognitive testing, ask about technology use, a bunch of different questionnaires there. They do it in the clinic once. We send it home. For the first week, we have check-ins to see if they are playing it regularly. We're asking them to play 4 times a week on week 1 and 4 times a week on week 2. So 8 times total at home. And then we have a final check-in at the end of the second week, and they return the equipment. And we don't call them in the second week because we wanted to see how much they would continue to use the phone in the second week without prompting from us. This is our group thus far. So 50 cognitively normal individuals, 70% female, so a bit of skew there. About 72 years old, highly educated. This is a function of our cohort. And I think this is an area where we definitely want to work on getting a wider range of individuals with educational status. We have 60% white, 38% Black, and 2% multiracial individuals in our cohort, and average MoCA was 26. And these are some of the cognitive measures that we're doing in addition to the yearly UDS testing. And so this is the everyday tech use in our users, in those 50 users. So as you can see, a lot of them have a smartphone. Of those that have a smartphone, this is how they use it. So this is calling, texting, emailing, playing games, using it for a calendar, and social media. So relatively high users that are using it. But within that, we've got some folks who just don't use it all that much. And one of the coordinators in my lab has taken a look at those who don't use the technology a lot versus those who do, and saw that initially they perform worse. The low users perform worse on the testing, but within a couple of sessions, by the end, they perform equivalently and they engage equivalently, which was nice to see. So when we looked at the low tech users versus the high tech users, this is how much they used the task at home. So we asked them to participate in 8 sessions. They're averaging about 11 sessions. So they're participating more than we asked them to, which was a surprise to me that they would do that. And they're doing it over both of the weeks. So the week when we're reminding them and the week that they are the second week. 66% are playing those extra sessions. And this is about how long it takes. So about 11 minutes each time. They're doing morning and night. We're not really seeing much difference there in performance, but we're looking at that data. In terms of the usability, so their feedback to us on whether or not it was easy to use the app itself, we use the IBM questionnaire for the usability upfront at the first visit, and got about 8-point ratings for that. And then after the 2 weeks of at-home use, we use the PIT mHealth app usability scale, and we're about 6 there. And we also ask for qualitative feedback on aspects of the app so that we can collect that for future improvement. This was their ratings of acceptability across the 3 tests. So we asked them, is it too easy, just right, or too difficult? And these were their ratings. So after day 1 and at the end of 2 weeks. And you can see there's a difference in these where they generally think that the concentration memory task is just right. The brick drop task and the space imposters in particular, they are rating as too difficult. And I think one thing that is interesting about this is that the memory concentration game is really the only one that is adjusting to their level of performance, and whereas the other 2 are not. So I guess in that way, it's not as surprising that they would find those harder because they're not really matched to their performance. This was their level of enjoyment out of 5. Space imposters not as high as the other ones, and likelihood to play again. And we asked them, would you prefer to do this or come into the office for testing? And many of them, the majority, would prefer to do phone testing, which is good for us to know. There are things that we're going to have to do in person and things that we'll need to do with regular paper pencil testing for now. But I think the acceptability and the willingness is there for this to be a tool, at least in this population. So this is some of the data on the tasks themselves over sessions. So this is the first 9 sessions. So session 1 is in the clinic, and then the first 8 sessions that they did at home. Since we had people that did more, we're just looking at the first one so that we can kind of look at practice effects and those sorts of things across the sessions. So these are their performance on 8 cards of the memory game, 12 cards, and 16 cards, comparing in the dashed line those lower levels where they're similar pairs and the non-lower levels where they're not similar pairs. And they sort of perform the way we would expect. The lower ones are a little bit harder, and it of course gets harder as the numbers go up. This is the brick drop or the Stroop type task. So this first one here, this is the inhibition measure. And so again, this is over those 9 sessions. We do see some practice effects over the first 3 to 4 sessions, and then some leveling off there. So that'll be helpful for us to know, which data would we want to be looking at? And does this practice effect change over time for folks? Is this something that can be used as a marker? We've seen that in some other groups who are doing these kinds of tests over time, that you can be using that practice effect as a marker of health or not in brain aging. And then the last of the 3 in terms of the reliability, we're seeing, again, some practice effects there initially, and these are 4, 5, and 6 pairs. And then across time. So a little bit of practice effects in the beginning, and then some leveling off over the course of those 9 sessions. And then here we're looking at across the measures for brick drop, concentration, and space imposters to look at the number of guesses and how that performs over time. We see for space imposters, expected kind of change over time for the 3 different pairs. One thing that we're seeing with the brick drop that is an area that we need to improve on is we're hitting ceiling on the first two trials. And so we're thinking about making an adaptive design to this for our patients, because we really can't go with one size fits all response time expectation. And so an adaptive design is something I have a student this summer, an undergrad, who's going to be working on that. And then for the concentration test, we see the sort of expected change in guesses over the 3 different levels, and also the expected difficulty in the lower levels versus the non-lower levels. So that was just sort of to check to see if the performance is as we would expect on these tests. And then we started comparing to some of our typical neuropsychological measures that they're doing every year when they're coming in. And here we're looking at the memory task again. So this is comparing those who are able to achieve a high card level, so kind of work their way up through 6, 12, 16, and more cards, versus those that aren't able to achieve a very high card level. So they're not performing as well on the memory tasks. And we see differences in those groups on their working memory load capacity, not that unexpected. We're seeing differences in those groups on their figure delay, and also on some of the other measures, in this case, trail making B. So, we're looking to see for these tests, they are likely going to map on to multiple tests within our typical battery, and seeing how we can kind of tease apart some of those aspects of these tests. So looking at the correlation between the 3 tests and some of the sort of typically used in the preclinical AD area. So this is the PAC-5. It's a combination of the free and cued selective reminding tests, animal fluency, in this case, the MoCA, and symbol digit. That makes up the PAC. And so we looked at Z-scores for both the PAC and their ability to complete one of the harder levels of the memory task. And we see a pretty good correlation between those two as sort of a first proof of concept there. And then looking at the brick drop task, we do have the straight up paper and pencil testing. And so we're able to look at more of a direct comparison there of how people are performing on the paper and pencil test versus the brick drop test. And we're seeing pretty high correlations between those two. And then similarly on the symbol digit substitution test, the paper and pencil test compared to the space imposters, this is the hardest level of it, also seeing pretty good correlation between the two of those. So far, what we're seeing with these tests and these 50 folks are that the participants are engaged. They're willing to do it. They're willing to take it home and try it and do it over time. They're pretty reliable over time with some practice effects that we'll want to keep an eye on. And we're seeing some preliminary validity with some of the standard measures. And we want to understand more about the components of these different tasks so that we can further understand how they're related to both early biomarker changes and change over time in these folks. So we'll be exploring, there are many different components of the tasks that we haven't gotten to yet because it's a digitized, we can collect so many different variables. We haven't gotten to so many of them. So we're working on that. We're looking at evaluating the relationships between those performance markers and imaging and blood-based biomarkers. And we're starting longitudinal collection as well. So people who are coming in a year later so that we can track people over time and see if there is more sensitivity in some of these measures than we would typically see in the measures that they would come in for. We're also collecting social and structural determinants of health data in our whole cohort now. So we'll be able to look at some of those factors and look at the way in which they may influence or be able to give us more information about healthy and unhealthy brain aging, resilience factors, factors that are impacting risk in our participants, and how those might be related to typical performance on our regular cognitive measures, and then on these as well. So we're at about 2:55. So I'm just going to mention the other app that I was talking about, and I will see. I'm gonna kind of move forward in the slides. Let me see if I can do this without having to stop it and go back. So about 12 years ago, we started an intervention program targeting, modifiable risk factors. So helping our patients with MCI try to do things like increase physical activity, increase cognitively challenging activities, and so forth. And so we there are many different groups out there that are doing different kinds of intervention programs. There's the habit program you may have heard of that has a structured approach to this. There are some of the much larger studies that are looking to do intervention in behavioral change. And so we had created a program to try to make some of that more structured for our patients because they really wanted that. What we found over time was that it took a lot of time and effort on the patients at part and on the staff. And what we saw was some, we did an 8-week intervention program that was very time intensive. We saw some improvements in some depression and anxiety variables. But what we really wanted was to be able to increase the number of people who could benefit from that. And so along with Lauren Massimo, who is a nurse researcher in our FTD group here, who's very much interested in goal-directed behavior, we got together to, and I'm just skipping ahead a little bit here, to develop a mobile app to help with increasing goal-directed behaviors, to help both patients and family members. with the idea of targeting initiation, planning, and motivation. That was sort of the underlying approach. And so we did a 2-phase study where first we piloted, got feedback, did some focus groups with care partners and dyads. And then we piloted an intervention app. And so I don't think I have time to go through this, but one thing that I will say is that in order to create the goals for this app, we used something called goal assessment scaling, which was a process of coming up with goal areas for individuals that were set on a standardized scale. And I think that was a really helpful approach for this particular type of study, where you can have each individual have very different goals, but they are standardized so that when you're looking at outcomes, you can look at them across a standardized scale. And so I'll skip ahead to this is the basic interface we had. We were really interested in focusing on increasing brain health, body health, personal and sort of chores and housework, with the idea of increasing activity in the individual, decreasing burden on the care partner. And so those were the two main goals. When we looked at the folks who were in our group who had MCI, AD, and BVFTD, we had, I believe it was 8 in each group, 8 dyads. We saw that they used the app, which was programmed with their individualized goals. And they used it over the 4 weeks that we had them, they had the app at home. The use decreased a little bit over time, but even at the end, they were continuing to use it, which was good to see. And so that was in 4 weeks of intervention. And then when we look at their goals that they had set out at the beginning of those 4 weeks and checked back in on that goal assessment scale, what we were looking at was, did they achieve the goal at the expected level? And this was folks who achieved it at the expected level, and then those who did those goals a little bit more. So maybe it might be something like going for walks on a daily basis. That might be much better than expected. What we had set as their goal is maybe, once a week, twice a week. And so we were looking to see in these 4 areas if the prompting, the motivation, the initiation, and the planning of the app was helpful to them in carrying those out. And so I know we're way over time, so I'll just go to the very end and note that for the 2 apps, the first one, we're continuing validation in the cohort. We have a pretty diverse older adult cohort that we're collecting this data in, diverse in terms of racial diversity, not necessarily in terms of socioeconomic and educational diversity. So that's an area that I think is necessary to attend to and to look to in the future to improve upon. And then for the second app, this was something that was really built for the participant. But I think what we learned throughout the group itself and the intervention itself is that what would be helpful, and the feedback that we got from the care partners, is that they wanted to be involved, but at a distance. They wanted to have a way of sort of being able to prompt their loved one, but not nagging them, using their own words. And so, that is something that I think would be a next step for this, is to be able to have a sort of a paired app that would be helpful in making changes to those goals at a distance, setting reminders in that app for the participant, and seeing if that is a helpful change, and helpful for allowing the autonomy of the patient and the care partner to have less burden, but to still be able to be involved in a way that they feel like they should. And lastly, but certainly not least, thanking all of the collaborators that have been incredibly helpful in developing and putting these tasks into place. The developers of the app itself, the research staff, and the trainees who have come through on a yearly basis, who have been incredibly helpful for brainstorming and making changes and really bringing new fresh information to these projects on a yearly basis, the funding sources and of course, the participants in the ADRC and the patients in the Penn Memory Center and the FTD Center for all of their time and effort and willingness to take on a new phone, even when they already had one or didn't like technology. So I'm sorry to have to run through the second one, but that study is now published in neuropsychological rehabilitation. So that one, at least there's some more information out on that. I am happy to stay for questions if people have questions or comments. So happy to do that.
Thank you so much, Dawn. I enjoyed learning about this. I really like your ideas for future work. Some of the caregiver involvement stuff is intriguing. And I'll move really quickly because I know we're a little bit past time. You guys can raise your hands if you have a question and we'll call on people. I recognize people have to hop off because they have other things to go to.
I have a question. Dawn, that was really very, very interesting. And I really like the intervention work that you're doing now. I think, we need more of that. So the ideas that you have there are really interesting. I did want to ask about your thoughts on now there's lots of different groups who are developing these different cognitive tests, right, to use on the phone now and to use remotely. And I love your gamification aspects of it. I think that those are like really exciting and probably why people want to, use those tests. What are your thoughts? And there is so much work to do, and you're doing a lot of that careful work in terms of like reliability and making sure it can tell the differences between groups. What are your thoughts on how we're going to bring all of this together at some point?
Yeah, I think you're right. There's a lot more to do. I think that what I imagine is that we're going to hopefully see the components of the different apps that people are making that are most sensitive and useful and reliable and engaging. And my hope is that there's enough open science and willingness to do that, to combine the elements of these different apps, and that they don't become proprietary, so that we can continue to combine, change, improve, and really take the best pieces of different groups' work and put them together. And I think maybe some of the NIH Mobile Toolbox work, the idea, I think, with that work, in addition to some of the assessments that they are making themselves, my understanding is that the idea of that is to also have a platform where you can use an app, put an app in and test it, and others can do the same. And there can be data that's pulled in from lots of different groups, so that that information can be collected in kind of a public repository and be able to be used together to optimize.
Oh, excellent. I hadn't heard about that initiative. That's great to hear.
Can I leverage your question, Maureen, to ask you, Dawn, you mentioned the need for uniformity of interfaces, but also want to support people's existing technology. And in addition to that, speaking as the designer engineering side, having an app or device specific app is a pain, because every time there's an operating system update, you have to change all your software. And so it's a constant chasing game. That combined with this push to bring everything into one platform makes me ask, what do you feel about having web-based activities that you can access from any device? So you have a uniformity of interface, but diversity of the entry mechanism.
Yeah, I think that can probably help with some of the operating system issues, right? To have that. I still wonder about the response time and speed of the physical devices, right? I think so. I think you can solve some of the problems with that. I think we're still left with some of the hardware issues, right? Of what is the device that you're using those tasks on, and we just can't get around. They're changing so fast. Everything, all of our devices are changing so fast that it's really hard to get around that. I think people who can come into this space and give ideas and procedures for how to adjust as those things are changing are such important partners to being able to figure this out. Yeah,
I agree.
Yeah.
Well, any last questions?
I think there's one from Larry Holder.
Oh, sorry, Larry. Yeah, I see you. Go ahead.
Yes, hi. Just real quick, in your slides, I think you said there was a 66% of the people, enjoyed doing the app, and I assume the other 34 would prefer to go into a clinic for their testing. And I guess the question is, do they want to do that because they don't like the technology, or because they don't like the isolation and want to go see people when they get there?
That's a great question. And it's a little confounded by some of this being collected during COVID. But we did ask follow-up questions about why, and the majority of the responses were exactly what you said, the isolation. They like coming in and talking to people, and I'm not sure if that's more the case because they were coming out of COVID isolation and this was like an opportunity to be with people where they felt safe and everyone was masked, but they still had people in the room. But it was by and large about the connection with individuals rather than the technology. Yeah.
Okay.
Yeah.
All right. Thank you.
Sure. Samina Rahman.
Mine's a really quick question, but yeah, thank you so much for the fascinating talk. For my question, I was wondering if there were common themes across the qualitative feedback from the participants from the smartphone cognitive assessment.
Yeah, so we haven't looked at all of that data yet, but from what I recall, they generally liked playing the concentration game. They felt like it was fun. It felt like a game to them. They didn't feel like they were kind of under the press of time as much as the other two, which they certainly were under press of time on the other two tasks, and generally liked that better. The feedback on the sort of gamification components was that some of them did play games and they felt like this was just another game for them to play. And so they were interested in that. Some of them, we had a couple of people give feedback on wondering whether or not they could play these games to try to improve their thinking, which, as using it as more of a training device rather than an assessment device. So that was something that we got questions on from folks as well. Yeah, I think that was a lot of the feedback.
Awesome. Thank you so much.
Sure.
Any other questions? Well, thank you again, Don. I'm glad that we made it through all of the technical adventures and appreciate your time. This was exciting for us. I think we're motivated to look at some of these issues.
Well, thanks so much for having me. I really appreciate it and appreciate everyone working through the technical issues as well.
We got there. All right. Thank you again. Enjoy the rest of your day, Don and everyone in the audience.
Thank you. Good to see everyone. Take care.